has been introduced, so I don't need any further introduction. I bring you greetings from the Baton Rouge University Teaching Hospital. That's our logo there for learning and culture, and from the OAU Teaching Hospital complex as well in Lake Edison, where the day breaks. The day hasn't, we don't have daybreak here everywhere in Nigeria is still in dark. All right, let's start. I have no financial declarations. I have no conflict of interest. All the videos that will be used in this presentation are mine, and I have consent of the patients to use them for training purposes. Some of the pictures are iceberg pictures, and I've got separate references we believe in those areas. So for the background, as we are using, you will see it ranging from between 3 to 8 per thousand live births. That's significant. And so cardiac assessment should ideally be done for all women. In the UK, we will routinely do this for all women as a basic scan when they do the anatomy scan. And in highly experienced hands, we can pick up to 90% of major forms of congenital heart disease. So why do them? It makes it easy to plan on the part of the physicians as well as the parents on what to do next. It also allows for planned deliveries. Um, they have commission centers in a place like the UK, for example, where people with congenital heart diseases are managed, and so it makes just give me a minute. It makes it easier to follow up. Importantly, as well, sorry about that. Importantly, the option of immediate postnatal treatment for some babies who may have doctor-dependent cardiac diseases are made available, and it is of great value to be able to declare normality in situations where we have done this kind of it is normal. And the indications, as I said earlier, ideally all pregnant women should have some basic cardiac assessment of their fetuses. And that's because we know that majority of cardiac anomalies happen in women without any non-release factor. There are some women who have had at least who have had one child with congenital cardiac disease, what we call the sibling risk. And the OETHC is one of the centers that perform open heart surgery in Nigeria. And this has made it very important that we're able to do some screening when the parents of those pediatric children have another. Again, the presence of one anomaly is an indication to screen for other anomalies. So usually once we see one congenital anomaly, we should aim to um, screen the heart as well. Other medical conditions such as collagen vascular diseases, viral infections such as rubella and cytomegalovirus, pregnant women with known chromosomal problems, increased nuclear translucency, genetic disorders with known cardiac associations. Um, Even if the parent does not currently have a cardiac problem, but the genetic disorder is known to be the type that predisposes to it, then we should screen such pregnancies. How about the timing? It's best done between 19 and 22 weeks. It may be done earlier if we think that the fetus is at the risk of having is at major risk of having a problem, and that's from about 14 to 16 weeks. But usually, if we do this, we will still review at about 22 weeks. It's important to also note that some conditions manifest progressively as gestational age advances. And so, if we do a fetal echo at about 20 weeks and we are not convinced, it may be advisable to repeat at about 28 weeks if we're not convinced that it's completely normal. And again, as part of my own routine, I scan all patients that have done an echo from 20 weeks. I scan them again at 28 weeks to confirm that everything is fine. So when we do a fetal echocardiography, what are the things that we check for? Um, Assessment of cardiac size, that's the cardiothoracic ratio, the position and axis of the heart, reading structure, atrioventricular, ventriculoarterial, veno-arterial concordance. I will show what I mean by this. The function of the heart as well. It's important that I emphasize that to be able to assess the structure and function of the heart, then we must have a good understanding of fetal circulation itself. It's only after that that we can then know what to expect as we move along. What are the ultrasound modes for fetal echo? The most critical is still the B mode. So the common excuse that I get from some of my friends and associates that my ultrasound machine is not sophisticated, so I don't check the fetal heart often. Um, it's not necessarily telling you actually. If you have a B-mode machine, then you can do an appraisal of the fetal heart. There are other modes that are very helpful, the M mode, the color mode, spectral pulse wave mode, and the 3D, 4D mode. The 3D, 4D is just coming up for assessment of crucial relations. The pulse wave mode you don't have to use when you are doing a basic scan. Trusting mainly the B mode and color wave today. And if you have a machine that can do B mode, M mode, and color data, then you can go all the way actually. So before we start, I have this advisory, and it's important that we all take note of these. Um, these are the basic requirements that you need to do a fetal echo. Always good to start with the normal so that there are little expectations. In other words, when you have a woman who is doing routine scan, no expectations, everything is fine, those are the kind of patients that we should start to practice fetal echo on. So don't wait until you see a fetus with a congenital anomaly and then start to practice echo on that same fetus because the expectations are higher at that point. You need a very steady hand, and this comes with practice. So you must be able to practice and keep your hand steady when you scan on one spot. That's very important. A good hand to eye coordination, and you must be able to move over a short distance at a time. We're talking about 2-3 millimeter movements. So it's important that the probe movement is transverse. Yeah. So the orientation of the probe is transverse all through. Yes. Sorry. The orientation of the probe is transverse all through at the basic level. So everything I will discuss today will be the transverse scan. It's also important to narrow the sector of the beam so that you can concentrate the beam on the heart. Some machines already have cardiac preset, like the machine I use currently. The one I used to use before does not. But the one I use currently already has a cardiac preset, and that makes life easy. I said earlier that some anomalies manifest as gestational age advances. So almost always when I do a cardiac echo, a fetal echo at 20-22 weeks, I tend to see those fetuses again at about 28 to 30 weeks for follow-up. This last bit comes from experience. Fetuses love to move, and I remember that when I was doing my training, every time I try to get a view, the fetus will move. Or whenever my supervisor or my trainer was doing hard, the fetuses seemed to cooperate better. And so one day I asked her, why is it that when I scan, the babies were always moving, but when you scan, they stay? And I said, because you have to follow them. If you follow them, it's as if the baby is staying. But if you stay and expect the fetus to stay, then you're going to have a critical session. All right, so let's start. The important thing here is when you start to scan, you must be able to determine the position of the heart. And to be able to determine the position of the heart, you must be able to determine the presentation of that fetus first. As you can see here, if the fetus is, in this instance, the fetus is bridge, and in this instance as well, it's bridge. So the left side is different for these two fetuses. And again, when the fetus is cephalic, it's also different. A basic rule is to assume that the stomach and the heart will be at the same side. That's a basic rule. Um, and almost always it works. Almost always works, except in situation where there is complete cytosine inversion, in which case the stomach and the heart are on the wrong side. So if you restrict yourself to assessing cytos by confirming that the stomach and the heart are on the same side, then the day you get a complete cytos inversion, you need the diagnosis. Again, this is just setting the background for the scanning session. You need a panoramic view, and in that panoramic view, look at the heart and compare it to the circumference of the chest. What do we have? You see, the circumference of the heart is just about 1/3 of that of the chest. That's what we call the cardiothoracic ratio. If you draw a straight line from the spine to the sternum, you see that the interventricular septum is about 45 degrees to the straight line and imaginary line there, and the axis is to the left. Okay, the left ventricle, as we know, forms the apex of the heart, and just behind it is the left atrium, the right atrium, and the right ventricle. So this is a panoramic view of the heart when we are starting to scan. Now let's go to echocardiography proper. In theory, there are just two cardiac views that you need: the four-chamber view and the great vessel view. And 60% of cardiac anomalies that are diagnosed in utero are diagnosed on the four-chamber view. And up to about 2008, 2010 actually, this was the only view that we need when we do fetal echo. But it's now realized that you will increase the diagnostic rate if we increase the great vessel view. and 40% of cardiac anomalies will be diagnosed on the great vessel view. In practical, you need about you need about 5 views actually. To start a fetal echo, you need to start from an axial view of the abdomen. That's where we start from. And then you move to the four chamber view. The great vessel view has three components: left ventricular outflow tract, the three vessel view, and the aortic duct. I'll put a star on this because some guidelines still don't think that you need to routinely do aortic duct. But I'll give you an example and an illustration of why I always do an aortic duct when I do a fetal. So these are the cardiac planes. As I have told us, they are all transverse, and these are the 5 views that I have mentioned. Start from the lowermost one here, that's the fetal abdomen, axial view of the fetal abdomen. From there you move up to the four chamber view at that level. From the four chamber view, you move up to left ventricular outflow tract, the three vessel view, and the aortic arc. So for a basic echo, that's all you need. These 5 views that are put here. And remember what I said, they are all transverse views. So those are the cardiac planes. Let's move on. I also mentioned that we need to have an understanding of the basic anatomy of the fetal heart. So remember what I said, the left ventricle forms the apex, right ventricle behind it, right atrium, left atrium. There is a very important adaptation here, as you will see, that there is a physiological communication between the right atrium and the left atrium, what we call the foramen ovale, which shuns oxygenated blood to the left side of the heart. And so it is normal to see that communication in the atrium, but there should be no communication in the ventricle. Okay? So I'm halfway through now. This is just a joke. The FH is there. When I scan, I run some of my scanning sessions with some of my residents, registrars and senior registrars. And this concept came to my mind. There was a day we were scanning a patient, and I could see clearly that there is a cardiac problem. But my senior registrar wasn't seeing it. So even when I asked him, how is the baby's heart? He just replied and said that the fetal heart is there. And so the important message from here is, after this lecture, move let's aim to move from just saying the fetal heart is there to actually having some good view of the fetal heart. Do we get it? Great. So I told us that we start from abdominal circumference. From the abdominal circumference, you see that's where the view starts from.
Hello, Dr. Ibrahim. Your audio is off. Hello, your audio is off.
And from the abdominal circumference, that's where you move to the next level, which is the four-chamber view. So let's go on from there. So that's the abdominal circumference. If you get that exact view of the abdominal circumference, then move. I realize that the common mistakes that we all make, and I used to make that a lot, um, was to start a cardiac scan from the fetal chest. Because when you start from the fetal chest, it becomes difficult to get the four-chamber view. And although we can see the fetal heart beating and we know that the FH is there, but it becomes very difficult to have that view, that correct plane that we want. So if you start from the fetal abdomen, then you will be fine. So from the fetal abdomen, you move up to the chest. And when you get to the chest, one of the things I want us to look for is this panoramic view in the chest. And in that panoramic view, what you see is the heart, and the heart is occupying about one third of this um, entire chest. Okay, you can see a thin rim of fluid here. If you look carefully, you see that rim of fluid around there. That's the pericardial fluid. And sometimes people tend to make a cardiac effusion. If you draw that straight line, you'll see, if you draw the straight line, you'll see that that's the apex of the heart is at about an angle less than 90 to the imaginary line. And this is the starting point. Now let's go to the four-chamber view. In the four-chamber view, there should be two atria. You must be able to count four-chamber convincingly. There should be two atria of comparable sizes, two ventricles of comparable sizes. You should see the interventricular septum clearly, atrioventricular septum on this side and atrioventricular septum on the other side as well. Um, if you look at the apex of the heart, compare the two ventricles, you will see there is this increase at greater band gives you a clue into what should be the apex of the heart. The first thing that comes to mind here that becomes obvious is how straight the atrioventricular valves are. You can see that. And remember what I said, it should not be a straight line. There must be some degree of offsetting. But here, it's a straight line, and the septum premium is not visible. Unlike this one, that's a septum premium. But here, the septum premium is not visible, and the two atria are not divided. This looks like a common atrium, okay? So when you see loss of offsetting and absent septum premium, this should give us an impression that there is a problem with the heart. In this instance, this is a complete atrioventricular septal defect, what we call an endocanal defect. And let's look at the next slide. That's the same fetus. In actual fact, the problems are multiple. One, there is congenital heart block, so we can see how slow the fetal heart is. Two, there is a common atrium, as we can see there. Three, the ventricles are small on both sides. And four, you can see that central defect. with the two ventricles connecting to a single atrium. Okay, so it's important for us, therefore, to pay attention when you do your four-chamber view. Look for the second premium and confirm that there is valvular offsetting, as I mentioned before. That's the video again. Now, left ventricular outflow tract. That is what is in the next level. We have now moved from four-chamber view. We're going towards the great vessel view now. The left ventricular outflow tract is just above the four-chamber view, and it is an image that incorporates the left ventricle with the outlet of the left ventricle as it goes into the aorta. In the normal heart, you will see this displaying the aortic origin, and it's very important that we get this as well. That's the schematic from it. This image is from ISO guideline. That's why I put this there. But I have a video that I'll be showing next of how to get the left ventricular outflow tract. If you are not able to get a clear left ventricular outflow tract, it may be that there is transposition of the great vessels. That's a possibility. It may also be that there is tetralogy of Fallot. Okay, so if we try and we cannot get left ventricular outflow tract the way it should be, then this will be an indication to assess that fetal some more. So let's look at the video. That's the left ventricle there, that's the right ventricle. And when you move just slightly upward, about 2-3 millimeter movement, you will see as the left ventricle enters into the aorta. This is what I want us to get here. That is it there. That's what we call the left ventricular outflow tract. As I said, you just need a few millimeter movement upward towards the fetal head. So when I mean upward, I mean cephalus. The fetus is the reference now. So move from four-chamber view, a few millimeters cephalus towards the fetal head. This is the view that you will get. That's the left ventricular outflow tract. Okay. The next view after the LVOT is the three-vessel view. And this three-vessel view gives us the arrangement that we will get if the outflow tract of the left ventricle and that of the right ventricle, and if the outflow tracts are normal. If I may take us back a little to this image, this image. So we have moved from, this is where we are now. We are somewhere here. That's the three vessel view. And I've brought us here so that we can have an idea of what forms those three vessels. You are looking from here. So the first thing you will see is the main pulmonary trunk. After the pulmonary trunk, the next one will be the aorta. And after the aorta, the next one will be the superior vena cava. The arrangement of these three vessels is what constitutes the three vessel view. And why do we need these arrangements? Why is it like that? You will see that from the right, the pulmonary trunk moves towards the left. And from the left, the aorta moves towards the right. And this is what we call the arterial crossover. And this is why I said we must have a good understanding of fetal circulation and anatomy in order to do a fetal echo. So what I'm going to be showing us next are images of the three vessels. Remember, pulmonary trunk, aorta, and the SVC. Okay. And there, that's that's the iceberg image there. This is not very clear, but it gives an understanding of what we are likely to see. That's the main pulmonary vessel, aorta and the superior vena cava. Pulmonary vessel there, aorta there, and the superior vena cava. I think ISOC should probably come to take my image for their next guideline. So this is the schematic from icework. Remember again what I said, main pulmonary trunk, aorta, and the SBC. And this is it there. This is what we call the three-vessel view. This is a bit up actually because you can start to see the trachea too here. But essentially what we need is main pulmonary trunk here, the aorta there, and the superior vena cava here. If you can see these three arrangements, and the other thing you will notice here is that the main pulmonary trunk is the largest, the aorta is intermediate, and the superior vena cava is the smallest of the three vessels. It is also important that this arrangement is preserved as well as the gradient of sizes. So if you see this, you can be sure that the arrangement of the blood vessels are normal. From now, let's have a look at a video of the three vessel view there. You only need to move another few millimeters upward and you get that. So that's the main pulmonary trunk, excuse me. That's the aorta and that's the superior vena cava. So remember that the main pulmonary trunk comes as a single vessel from the heart and then divides into two, the right and left pulmonary arteries. So you will see the bifurcation here of the pulmonary vessels from the main pulmonary trunk. Importantly as well, excuse me, importantly as well, we will see that the color flow in the pulmonary trunk and the aorta are essentially the same as blood moves away from the heart towards the probe, whereas in the superior vena cava, blood is moving in the opposite direction because that's a venous flow and it is taking the blood from the upper part of the fetus to the heart. It's important that this arrangement is preserved as well. So if you have color flow, you can check your three-vessel view and color flow too. After the three-vessel view, the next thing I want to show us is the arc of aorta. So that's the arc of aorta there, and what I'm trying to show us there is how the three-vessel view transforms into the heart. That's the pulmonary trunk, that's the arc of aorta, and the SBC is somewhere up there. This arc of aorta view is another few millimeters upward, and it's not compulsory to show this in the guidelines, in some of the guidelines at the moment. But as we realize that some fetuses may have a normal three-vessel view and still have problem at the level of the arc of the aorta. This, of course, is transverse view as well. And as I have said, all these views in basic fetal echo are all transverse views. So that's another transverse view there. And this will be the last view that we need when we assess fetal echo. Okay, so this is one of the cases I'm managing at the moment as well, what we call a right-sided aortic arc. If you look here, that's the normal three-vessel view. Remember these arrangements, pulmonary trunk, aorta, and SBC. Okay? If there is a problem with if there is a problem with the aortic arc, such that the blood is not flowing properly from the aorta to the SBC, then this here are the cartilages of the trachea, and that's the lumen of the trachea there. And you can see the vessels arranged just by the side of the trachea. But if the aorta does not take the normal course and the aorta is right-sided, this is what you get. And this is the ultrasound image of the fetus that will develop a vascular ring around the trachea when that fetus is born. So in this instance, for example, it may be important, some of them may be asymptomatic, But sometimes these vessels will cause a constriction around the aorta, around the trachea, and at delivery, the managing team here must prepare for respiratory distress in this baby when the baby is born. And this pregnancy is ongoing. We are going to MDT this baby soon in my center because we have regular discussions between cardiothoracic surgeons, pediatric cardiologists, and the fetal medicine units when we have fetuses like this. So this is an ongoing pregnancy showing abnormality at this level with a right-sided aortic heart, so that instead of having this arrangement, this is what we have. So essentially, this is a basic fetal echocardiography made in Nigeria in 30 minutes, which is the time that Dr. Nabudogo said I will have for the presentation. I'm sorry if I've been a bit fast. I'm just trying to cover what is important. In conclusion, it is important that all pregnancies are assessed, basic cardiac assessment, fetal echo required determination and grit, especially because some babies are just very playful, very stubborn. Just when you think you are getting what you need, then the fetus will move. And sometimes it's just difficult that you may not, in fact, get all the views in one scanning session. And about to do that, ask the woman to go after trying for some time, then maybe a week or so later, we'll try again. And the important thing is to know which view you need and just follow up and get it completed. It takes training, but beyond training, consistency is important to achieve competence in fetal echo. I'm sure we can do it. And prenatal diagnosis can significantly improve the prognosis. You see this type of fetus, for example, before this baby is born, you will make arrangements for intubation if necessary. So whoever is going to be around for this delivery will be somebody that can do the neonatal intubation. And this can eventually improve the prognosis of some of these babies that are born in Nigeria. And what we have in this instance, for example, is that the obstetrician delivers the baby, gives it to a neonatologist or something, and after about 10 minutes, there is a problem and there is a quarrel because the obstetrician believes I delivered the baby that was fine and I gave the baby to a pediatrician and a neonatologist. So what did they do to the baby? Whereas the issue was that we never knew before the baby was born that that fetus had a vascular web that could cause respiratory distress. So these are the kind of um, these are the dreams that we have, and we hope that we can continue to improve diagnosis prenatally in the country. Together we can do it. We can move beyond the FHs there to actually taking a good look at the four-chamber view and looking at the great vessels as well. That's my conclusion. I wish to sincerely appreciate the Health and Gynae Department OETC for the support. I mentioned pediatric cardiology department, cardiothoracic unit as well of OETHC. These are the units that I have worked with. The issue here is sometimes it's difficult. You look at it, you don't know exactly what is happening. And I just call the consultant from this unit and we'll do a joint scanning session. I'm saying this because as we all try to start this in our centers, it's important that we know that you may not be able to see everything just scanning alone. You may sometimes need to call somebody and ask for a second opinion. And of course, the Benefica Medicine and Obstetric Ultrasound Group, thank you so much. I appreciate the recognition and the invitation. That's a 3D of one of my babies. I'm saying thank you on my behalf to all of us for listening to the presentation. Thank you very much. Dr. Nabudozo, over to you, sir.
Thank you very much, Ibrahim. I'm sure you hear me. Thank you very much, Ibrahim. Do you hear me? Well, hello,
Hello, Dr.
hello.
Nabudozo. Are you there?
Yeah, yes. Are you hearing me, Ibrahim? Hello, do you hear me? Yes, I'm hearing you. Do you hear me? Hello? Ibrahim, do you hear me? Hello, do you hear me now? Hello? All right, I think I am being heard. Um, I want to say a big thank you to you, Dr. Ibrahim, for a wonderful lecture. Now, before I go on, let me quickly just make a few announcements because they are extremely important for the subsequent weeks. Okay, so we'll be finishing about 10 minutes, so I crave our indulgence to remain a little bit because I see most people are leaving now. Um, Again, just to quickly make some announcements that for further details of, wait, Ibrahim, at least I can see you. Can you hear me? If you can hear me, just raise your hand on your screen. Okay. All right. So I think it's hearing me. So fine. You can visit our website for details of all our previous recordings and also of the next webinar in case you are not in the blog and you do not have the information. Also, if you intend to reach us, those are important details that you may use as well. And then we had mentioned before that some of our friends in Wiri are presently carrying out the COVID tests, so you may contact them if you need to travel out of the country for a COVID test. Now, a very important announcement that I need to make is that for next week, for Wednesday, we'll be rounding up the 3 months webinar on Wednesday. And for that, it's extremely important. I apologize for this. It's supposed to be 12 midday. This is 12 midday on Wednesday, and we'll be rounding up on September 2nd with a lecture by Dr. Robinson. She's the head of fetal medicine at Monash in Australia. This is extremely important for us because we're trying to create a collaboration with that center. And so she has graciously agreed to stay awake that night to give us this lecture. I want to plead with every single one of us that belongs to a department to spread this message to the various departments and to encourage people as much as is possible to attend. It would be unfair to ask somebody to stay awake at night to give us a lecture because of time difference, and then the person comes in and finds only a few individuals. So please, I beg all of us. Now I'm going to give the details now, so you may just copy it, but it's already on the blog and on the website. So the the joining details for next week is 859. So in case you just want to write it down, 859 7503 9405. And the passcode is TWINGEST, TWINGEST. So I believe that will be simple enough. And that's the poster. So we have it on our blogs and also on the website. And we expect that every single one of us will join on Wednesday. So that's just 2 days from now, on Wednesday at 12 midday. I encourage all of us to join at about 11:45 so that we can sort out the issue of sounds and the like. Today, a lot of people have complained of the sound, but I think the sound was fair. There may have been some network issues along the way, but I think the sound on a general note was fair. I want to quickly just, so as we are rounding up this series, just permit me for the next 5 minutes to thank all those who have really helped us because Wednesday we may not have so much time because Alice has told me that she's going a little in depth on some of the issues that sometimes we don't even do in Nigeria. She has sent us a few issues for me to discuss with her later in the day concerning the practice in Nigeria. Some of these have to do with the issues of what our laws are on termination. Going and talking about multiple gestation, the issue of feticide becomes important. The issue of what the law says about termination, the attitude also of our women towards termination. They are all important issues which I should be discussing with her later today because she may be talking about them. So again, as I said, we are all encouraged to try and join. For this webinar series, I thank our group, all our facilitators who have been a part of the planning of this. But most especially, I want to thank Dr. Ibrahim, who incidentally started the whole series and is ending it. We really didn't plan it, but we just thank God that he fell in there. He took the first day. And this is essentially our last day, but Alice is going to cap it up with the icing on Wednesday. So Ibrahim and Dr. Shile from Jos. Chile was the first person who muted it sometime in January and said, what can we, no, sometime just after the COVID started and said, what can we do now that there's COVID? And we're really very grateful to these two and to so many others. I want to also thank some of our very senior colleagues who have made it a point of duty to attend virtually every webinar. I thank Dr. Professor Saturday Etuk from Calabar. He has been present for virtually every single one of these webinars. I also thank Professor Ray Igbeze. He's a very senior colleague, actually the second vice president of Sorgon. He has attended virtually every one of this series since we started. Dr. Ezenkwele has also attended almost all of them, apart from a few that she took permission. I want to also thank Dr. Joyce Ikubo, Dr. Janet, they are part of our group. Professor Bukar, he gave us a very beautiful lecture some weeks ago, and he has almost always attended all. My own prof, Professor Garuro, and his team from Liberia, they make it a point of duty. I've seen at least 5 of them in this webinar today, and I thank them. Dr. Chris Agbogoroma is in Abuja, a very senior colleague as well. He's always here. Dr. John Agbebia from Ogara, and many others. I also thank the Ghanaian group too. I've seen at least 3 or 4 of them at this webinar, and I thank them. We also have 1 or 2 participants and facilitators from Canada, and I also see them in this group. So we've actually gone worldwide, and we are glad for every single one who has made this possible. In the last 3 months, there have always been challenges with network and system breakdown, but we thank God that we have not missed a single day, despite the fact that sometimes the system just suddenly crashes. But we always made sure that we continued, system or no system. So for all who have made it a point of duty to belong to us, we say a big thank you. So as I end now, I saw that some hands were up. I don't know whether they wanted to make any comment, but if you intend to, in the next 5 minutes, just put up your hand and then I would give you permission to quickly make maybe a question or a comment and then we'll close. So you can use your system in case, okay, Shile has raised his hand, so let me ask him to unmute. Shile, you can unmute.
Okay,
Okay.
thank you very much, sir. Can you
Yeah.
hear me, sir?
Yes, I can hear you.
Okay, there's actually a question for Dr. Ibrahim. I don't know if you would want to make a comment on that. Someone
Just
said,
read it out. Yeah.
okay, considering the fact that the fetal heartbeat 120 to 160 beats per minute, is it possible to slow down the imaging so as to visualize the heart better? I don't know if Dr. Ibrahim can hear or he would want me to just make a comment.
I've asked him to unmute, so let him speak first. Dr.
Yes, sir.
Ibrahim, please. Dr. Ibrahim, I have asked you to unmute. I'm not hearing him. Hello? Okay, Shile, you can go ahead, please.
Okay, sir. I just want to say that some of the machines actually come equipped with the Cine loop so that some of the machines you could see it. It could either be a dedicated button or like for some of the machines you could just scroll back on the tracker ball. And once you do that, you're able to obtain some length at the speed at which you want to see. Some machines are actually equipped, you can choose, okay, do I want to slow down for 15 seconds, for 30 seconds, and then you will see it as slow as you want to be, and you want to see, and then you'll be able to identify all the fine details of the fetal heart.